So without further ado, let's invite Dr. Wei-Jian Chan, Vice President of National Health Research Institute, Taiwan, to come to the stage. Let's welcome Dr. Chan.
It's my great honor to introduce today's first speaker, Professor Yik Ying TEO. I don't know how to pronounce. Huh? TEO. What's the 潮州话? Zhang. Oh. But Dr. Zhang have a very unique background because he was trained as a mathematician in Imperial College for his undergraduate. But then he went on to obtain a Doctor of Philosophy in Statistics from the University of Oxford. And I think later he probably, pursued a research career in the modeling of infectious disease or something like that. And then he became Dean of the School of Public Health and also as the Vice President of National University of Singapore. So today he will talk about lung cancer in Singapore, prevention and screening strategy. Let's welcome Professor Zhang.
Good afternoon, distinguished guests, ladies and gentlemen. It's always a pleasure to be back in Taiwan with friends. But I have to say that it's a difficult time that we are all living in. Before I go into lung cancer, I think, because if we look at what's happening around the world, we do see that the mega trends of geopolitical tensions, it's really causing a lot of problems. Humanitarian crisis in Middle East, Ukraine-Russia war, and I think the world will get a bit more chaotic as the year continues. But I think that's where, if we look at humanitarian crisis, this is where we now bring in and look at what's happening in our part of the world. Because in Singapore, just like Taiwan, Thailand, countries in East Asia, including from where Professor Jim is in Japan, Korea, our populations are aging. And when we think about aging populations, this is really where we start to see a big problem with non-communicable diseases. And I would like to share with you some of the evolution of diseases, just to frame our thinking, because at the end of the day, what I will be talking about in terms of the strategies that countries take against NCDs must rely on your understanding of how financing works, how policy works, how health promotion works. Because if we see that countries have progressed doing well against infectious diseases, such as malaria, tuberculosis, dengue, HIV/AIDS, that's where maternal child health has improved. You have populations that are able to live longer because they survive the first 5 years, which is when most maternal or infant mortality happens. Now, if you have cleared that bound, which is what low and some lower middle income countries are still faced with. This is where populations have a chance to live longer. When you live longer, this is where you accumulate risk factors in your life. When you accumulate risk factors, what happens? Your body part starts to break down. Earlier on, our MC very kindly mentioned French fries. French fries actually is an ultra-processed food, which is not very good for you. But I think that is the risk factor that we are faced with these days. Living in a country like Singapore, Taiwan, Thailand, Japan, we are faced with quite a number of risk factors. We heard about air pollution. Imagine you survived the first 5 years of your life, and therefore you live until 50, 60 years old. You have 50, 60 years of sedentary lifestyle, breathing in the air, drinking water from plastic bottles with nanoparticles in it, breathing polluted air, and also eating ultra-processed food. This is where our bodies start to accumulate risk factors, which leads to the onset of NCDs. So we now see worldwide problems like diabetes, hypertension, stroke, high cholesterol, affecting many populations. There is a Lancet Commission looking at what is going to be one of the world's biggest threat to population health around the world. It is not nuclear war. It is not artificial intelligence. It is actually diabetes. Because when we start to look at most of the populations around the world, countries are aging. And if you accompany aging with high nutrition, with lack of physical activity, diabetes is a very real possibility. And the Lancet Commission actually identified that diabetes alone will cause the greatest deaths in this 100 years, from the year 2000 to the year 2100. But now I paint you another scenario. Let's suppose DG Wu and the colleagues at NHRI are able to very successfully combat diabetes, high blood pressure, stroke, and high cholesterol. What is left for us if we don't have this bundle of NCDs? You would realize that what is waiting for you will be cancer, as well as also mental illnesses such as dementia. So these are some of the thinking if you are now planning your health financing for the future. Health promotion is great because we are able to reduce the burden of NCDs. But then health ministries must also start to think about what are the diseases that are coming ahead, and then that's where you realize the threat of cancer is a very real threat. And why I highlight cancer? Because worldwide, governments are now facing a big problem. How do they finance cancer care? Because cancer treatment, cancer screening are very expensive. And when we start to think about the management of health at the population level, this is where you need to start to think about how do we tackle a problem such as lung cancer or other forms of cancer in a population that will be aging. And actually, when we start to think about this resilience against future pandemics, future outbreaks, our ability to keep our population healthy against NCDs, against cancer, is part of a health security approach. Because if you remember, not too long ago, 2-3 years ago during COVID-19, which are the populations that are suffering the worst of a COVID-19 infection? It is people with comorbidities with NCDs that are obese, or they have diabetes, they have cancers. These are the people, when they are affected by COVID-19, they have the worst outcome. So this is just a frame that I thought I would start off with as I now talk about lung cancer strategies in Singapore. Because you would see that many of the strategies that I'm going to talk about centers itself around very simple principles in public health, which is around promoting health, protecting people from accumulating the risk factors, as well as being able to detect early. And this is where being able to identify what are the best approaches that science has to offer in terms of detecting, in terms of prevention, helps ministries of health develop policies. And this is where I genuinely see the partnership between an institute such as NHRI, the National Health Research Institute, and the Ministry of Health and Welfare, DG Wu's unit, Health Promotion Administration. This link between NHRI providing the evidence to guide policy must continue, because this is the only way that you can develop the right level of policies. Now, as I talk about the policies in Singapore, I think it's useful to first start off with a very simple framing. What is the size of the problem? In public health, when we tackle a problem, whether it is malaria, whether it is TB, whether it is lung cancer, it is important to know how many people are affected by it, what is the size. In Singapore, you could see these are the top 10 common causes of cancers affecting men and women. And lung cancer remains as one of the top 5 for both men and women. In fact, it's the top 3. This is from the latest data in 2021. And if we look at this chart, this is cancer incidence. What about cancer deaths? Now, if you look at the chart on the right, the top 10 causes of death from cancer, lung cancer is at the very top for men, and actually it's the second killer for women. So once we get a sense of what are the problems for lung cancer, this is where we start to look at what about our detection rates. Now, if you look at the chart on the left, this is where you see that there are, across the horizontal axis, is a collection of data for 10 years, from 2008 to 2017. The block that are in blue refers to stage 1 cancer that are found, and then stage 2, stage 3, and finally the biggest block is stage 4. Now when you see such a plot, I hope you can start to understand that actually Singapore, you're still doing very poorly at identifying people with lung cancer early on. Because most of the people that we find are in late stages of lung cancer, are in stage 4 already. But there is some quite promising developments. You could see that across the years, especially in the last 5 years, the detection has been increasing because we now start to pick up more stage 1 cancer, and then we have fewer stage 2 and stage 3 cancers. But clearly, we are still not doing enough to pick up the stage 4 cancers. And this has to do with the level of literacy in Singapore, health literacy. I will speak about that in a bit. Now, perhaps it's useful to very quickly go in and explain a little bit about the two types of lung cancer. There's non-small cell lung cancer and small cell lung cancer. But I think regardless of whether we are talking about which type of cancer, there is a very simple message here, that the earlier you are able to identify someone with cancer, the better the outcomes and the likelihood of a successful treatment. Now, when we think about cancer, this is really where we start to think about what are the risk factors of lung cancer. And this is where we have the traditional risk factors that we know about. From cohort studies, you will be able to identify whether it is lifestyle, whether it is environmental risk factors that are increasing the risk for lung cancer. But increasingly, I think we need to also start to look at new innovations that people are using that are potentially increasing the risk of cancer, as well as environmental exposures. So what are the traditional risk factors that we know about? It will be risk factors that are linked to smoking, tobacco use, as well as secondhand smoke. And just primary smoker, as well as secondhand smokers, actually account for about 85% of the lung cancer cases that we see. And this is why, unsurprisingly, when we start to think about tackling lung cancer, many countries will still have a significant focus on tobacco control measures. But at the same time, I think we have heard Vice President mention also that environmental exposures are increasing the risk of people, especially for lung cancer. And this is where, in the past, we have an occupational hazard that are linked to asbestos, that are linked to exposure to certain chemicals. These days, in a country like Taiwan, Singapore, we are less exposed because we have occupational health and safety rules that will minimize such exposure. But actually, we don't know for sure what are the risks from exposure to drinking plastic bottled water, to the type of food that we're eating, ultra-processed foods, that have been found to be associated with increased risk of all types of cancer. And more importantly, I think there is a new innovation that the world needs to understand very carefully, and it's called e-cigarettes, or electronic nicotine delivery systems, or in countries they call it vapes. Because this device, it's now causing the biggest problem of addiction among adolescents and youth. And it is a bigger problem than tobacco cigarette ever was in its 50, 60 years of history for young people. Because worldwide, regardless of countries such as Singapore, Thailand, Brunei, we have a strict ban on all e-cigarettes. You can't buy, you can't use, you can't own e-cigarettes. But in Singapore, we have a problem of e-cigarettes among youth. In countries like Japan, Australia, which regulates the use of e-cigarettes, the uptake of e-cigarettes among adolescents and children are actually very high. In a country like the United Kingdom, where Public Health England, back then when there was still PHE, explicitly stated that e-cigarettes, it's going to help with tobacco cessation. It is a reduced harm device. If you go to UK now, you can see what is the scale of the problem of vaping in that country. In my opinion, United Kingdom has lost all hope of ever trying to control its e-cigarette problem. You just walk down a street, in England, you could find 10 shops selling vaping devices. The street is not 100 meters long. So I think this is the kind of approach that we must continue to have to understand what are the new risk factors that are going to start increasing our risk towards lung cancer. And finally, of course, we have the genetic factors, the family history, the genetic mutations that does predisposes someone to higher risk of lung cancer. Now, the World Health Organization has made it very clear that when it comes to tobacco use, there is no tolerance. There's no acceptable limit. And the way that countries have been advised to tackle tobacco must be multi-pronged, including taxation, plain packaging, restrictions on advertising, having public spaces where people are most likely to go to be completely smoke-free, and also trying to increase awareness and literacy. I'm happy that Singapore have quite strong government policies against tobacco. We need to also have similar strict rules and enforcement against vaping. Right now, our tobacco taxes in Singapore ranges about 65 to 70%. We have plain packaging, so now you can't see the brand of the cigarettes that you're trying to buy, with also the graphic warnings. We have public spaces that people are not allowed to smoke. All of this is actually to help to reduce the ease that people are able to access cigarettes, to smoke cigarettes, and also to pass on the habit. Now, what about additional measures? Because when we start to think about what else can be done against smoking, this is really where we see that the greatest impact is likely to come from taxation reviews. How many countries actually review the taxes for tobacco cigarettes regularly? And in fact, actually, DGU stepped out because I wanted to actually ask, how often does HPA changes its taxation on cigarettes in Taiwan? Because that will keep up the momentum to reduce or access and make it more expensive for young children to pick up the habit. But that is tackling one very specific risk factor in Singapore. Generally, what are our strategies to prevent or to protect people against lung cancer? I think there are four. The first is, of course, as I mentioned, tackling the highest top risk factor linked to lung cancer, which is tobacco cessation and tobacco control. The second is making sure that at your workplace, you have the right rules and regulations with regular enforcement to tackle known cancer-causing agents. The third, as what VP has mentioned, is around your lifestyle, focusing on diet and physical activity. And finally, it is also around having the awareness to screen regularly for lung cancer. And I think lung cancer screening is a very tricky issue in many countries because it can cost quite a bit for a country to support and subsidize lung cancer screening. I'll come to that in a bit. So these are the range of approaches that Singapore does, looking at lifestyle, looking at tobacco control. Now, I'll just use an example of tobacco control in Singapore. It is a semi-successful story because we have a national program called I Quit. It is linked to helping people quit their tobacco or smoking habit. Many people know about I Quit. Not many people take it up. And of those that take it up, not many people successfully convert and stop smoking. So actually having a national program also means that you have to evaluate the program for its success and to determine whether you need to change the program and to improve it. I talk about the fourth strategy, which is around screening. Now, when we think about screening for lung cancer, I think the question always is, how do we make sure that we are able to pick up the right group of people? Because we know that early detection means you find it early, you find cancers early. Typically, they are at lower stages, stage 1 or stage 2. They are localized, they are easy to treat or to cut away, and then you have a greater chance of cancer-free relapse. So the 5-year survival rate is also dependent on whether you are able to detect cancers early. What are the screening methods that we use in Singapore? At the moment, we use the low-dose CT scan, which is a pilot program supported actually not by the government, but by NGOs, by non-governmental organizations in Singapore. And because the cost is high, we have to be very prudent and very careful with how we identify people to go for this program. So the pilot program here focuses on high-risk populations with a strong history of tobacco use. And the recommendation is to perform this screening on an annual basis. But the problem here is that this only focuses on specific high-risk populations that smoke. And at the moment, there are no health financing to help people pay for their screening if they want to. And what are the financing mechanisms that currently people can rely on? We have a compulsory health saving that people can use, but this requires a doctor to recommend that the patient in front of him or her requires a CT scan. We have a health insurance for the poor. This would be our UHC, our Universal Health Coverage Net, to help pay for expenses for the poorer Singaporeans. And finally, we have a subsidy scheme. But all of these schemes are not dedicated to screening for lung cancer, and in fact requires subsequent recommendation or referral by a primary care doctor. So this is one big gap that we currently have in Singapore when it comes to financing for lung cancer screening. Some of the challenges that we have for screening is actually around literacy. Earlier on, I mentioned that the awareness that lung cancer screening is important or is available or is even subsidized, can be subsidized, this awareness is poor. And so because of that, the uptake for lung cancer screening is poor. And that, if your screening rates are poor, people don't know that they have lung cancer. By the time that they present themselves to a doctor because of problems in their body, it is usually at a later stage. That's where you have stage 3 and stage 4 accounting for almost 80% of the population. The cost is also an issue. And this is where being able to address a financing framework for the country is important. And finally, I think in terms of false positives, false negatives, overdiagnosis, these are problems that accompany any cancer screening framework. Because when you screen for cancer, if there are false positives, it causes a lot of anxiety. So there are also the problem of overdiagnosis that is happening in countries with a buffet syndrome. If government comes in to pay for all health screening or all health procedures, there is a tendency that some people, not everyone, some people in the population will go and overutilize some of these services. And this overdiagnosis can actually create stress in the health system as well. So I think I'll quickly end off by just talking about some of the new technologies that are emerging, which is around AI. We are already experimenting with the use of AI to interpret some of the images to identify better whether there is a presence or an absence of cancer cells. microRNA technologies for non-invasive, it's a blood test. You are able to identify specific microRNA biomarkers to say that whether there is presence or absence of tumor-like cells in the body, and actually also population segmentation. Are we able to make use of electronic healthcare records to better predict which are the groups of patients that are likely to benefit more from such lung cancer screening? When I say benefit more, it actually means that my number to test or my number to screen in order to detect one true positive actually starts to fall because I'm able to stratify my population better. So you know who are the people that will be at higher risk for lung cancer. From Singapore's perspective, I actually think we need to change our legislation around lung cancer screening program and to provide financing aid. So I'll end off with 4 very simple messages, which is, I think, as with any cancers, being able to prevent is always still the best approach. The way to prevent or to minimize is to manage your risk factors. As with any cancers, being able to detect early is also useful, but this detection for cancers have to be very much guided by a risk stratification approach, which you need national financing framework to provide the financial support. So with that, I think I've reached the end of my presentation. Thank you very much, and thank you again once to the organizers for the invitation. Thank you.
Thank you, Professor Y. And let's invite Professor Wei Jin Chan, our moderator, to have the short Q&A session. 5 minutes.
5 minutes, okay. Where is the Jimba?
Thank you very much for your excellent presentation. About low-dose CT scan, I have one question. You talked about lung cancer screening as a standalone program. However, low-dose CT scan can detect COPD at early stage, and it can also detect vascular changes in the lungs. So are there any way of thinking to combine lung cancer screening and other lung disease screening together, which may be helpful to think about the burden of finance? If you can detect more diseases, it may be much better.
Thank you very much, Professor Jimba. But yes, so you are absolutely right, because the low-dose CT scan, in fact, when you scan the lungs, it actually tells you quite a lot of characteristics of your lungs that goes beyond just lung cancer. And I think that the approach is, how do we identify the right group of people to come in for the low-dose CT scan? Because the few conditions that you mentioned, including COPD, including lung cancer, the symptoms that a patient presents can be quite similar. And that's when they start to identify whether it is due to COPD, it is due to other pulmonary problems, or is it due to a cancer cell in the lungs. So the question then is, how do we finance and also stratify the group of population that will come in for the low-dose CT scan? I think at the point of scanning, the clinician's mindset is that there is something wrong with this person's lungs. We use a low-dose CT scan to search. And it is not necessarily specific to finding cancer cells.
Over there.
I'm Dr. Wing from the Professor Chohong's teams. Thanks for the Dr. YY. I learned about your presentation. I would like to ask you advance on the change in the screening stages. Screening is important from the NCT promotion. On the other hand, the genetic screening has a very significant start in the recent years. Do you think integrated genetic screening with traditional screening from lung cancer could enhance the benefit? And would you recommend the government in Singapore or Korea or Taiwan incorporating genetic screening into their lung cancer program?
Thank you very much for the question. So this question around the use of genetic biomarkers to stratify population for their cancer risk is one that needs very careful investigation. Some cancers actually work very well when you start to use genetic biomarkers. I will use the example of breast cancer. So for breast cancer, there are certain genetic positions in our human genome, especially for women, that are able to be quite predictive of the lifetime risk for breast cancer. So using those genetic biomarkers to now start to stratify women in the population to decide should this group of women come in for mammogram screening, not at 50 years old, but at 35, to start screening them early on. For breast cancer, the data actually is quite positive. Then, once you have the genetic evidence, the second layer is to perform the health technology assessment, the cost effectiveness analysis. Because the cost effectiveness will then tell you how many women do you need to screen in order to benefit one. And that will help the finance ministry determine whether to support early mammogram screening as well as to provide genetic screening or genetic testing for all women in the population. So breast cancer is something that in Singapore we have shown that if you use genetic tests to stratify women, even if I include all the cost that is included to test the genetics profile of a woman, it will still be cost effective to use genetic subtype to stratify. The problem for lung cancer is that there are no clear biomarkers at the moment that are as predictive as the case for breast cancer. So what we do know is that for lung cancer, there are a few genetic biomarkers that predisposes a person's risk if they smoke. But if the person doesn't smoke or is not exposed to secondhand smoke, actually the genetic biomarker doesn't necessarily increase the risk. So there is that gene plus environment interaction that comes in. So for those cases, it is harder to put a case that it is going to be cost effective. So that's something that we are still looking at.
Because of time, probably we need to stop here, but later you can ask Professor Zhang during the break. Let's thank Professor Zhang again.